Good afternoon, everyone. You're most welcome to this session. This is the very first session of this year, 2026, and I would like to say Happy New Year to everyone. These sessions CME sessions are organized by the Uganda Psychiatric Association or the Uganda Association of Psychiatrists, UAP, and we have every month one session on the last Friday of every month from 1 p.m. to 2 p.m. And today we are glad to be joined by our Professor Noeline. Thank you so much for accepting to take us through this session. But before that, we have our colleague, Dr. Lillian, who will take us through, who will be the presenter, taking us through the topic of today, which is the pharmacotherapy of pharmacology of managing Alzheimer's disease. So we are going to have exactly 1 hour, and these sessions award the CPD points. So a link for the CPD points will be shared just after the presenter, just after Dr. Lillian has finished to present. Before the Q&A, we shall have the link shared in the chat. So look out for the link during that time. We are going to have Dr. Lillian first, then Professor is going to join us in the Q&A. So please write your questions in the chat such that by that time we're able to share the questions and we have a very constructive discussion. Otherwise, I thank you all for joining today. As others join in, I would like to inform you that the recordings will be shared over the session, but also during this session, you will not be able to unmute unless you ask by the moderator to unmute. So when the host asks you to unmute, you will be able to unmute. But for now, I would like that we all utilize the chat and share our questions. So without wasting any more time, I would like to welcome Dr. Lillian to take us away. Over to you, Dr. Lillian.
Thank you very much, Dr. Mwanguzi. And thank you to the attendees for this session. As Dr. Mwanguzi has mentioned, I'll just give a brief of this topic, and then our content expert will take us through the Q&A to answer most of your concerns and key things you'd like to learn about this topic. I will share a case from our setting, and then I'll give a very brief about how to diagnose Alzheimer's disease, a brief about the pathophysiology, and then the pharmacological management, the available modalities, and then in the context to our settings and what is really being done in the practice currently, Professor will be able to bring us on board and educate us more. So this is a case of a 65-year-old male from Kagoma. His profession is a senior accounting advisor, and he studied up to master's level. He was able to give information, and also his daughter. The main concern that brought them to the clinic was self-isolation for a month. They reported that he was very fine, according to them, until about 1 month ago, when he requested for 1 month leave from work. That, according to him, he requested for leave because of his symptoms of progressive forgetfulness, and he had read about the symptoms, and then he realized he needed to leave off work, so he requested for that leave. Now, when he got the leave, the entire 1 month of the leave, he was isolating himself, was not moving out of his house, was not interacting with any family members or friends. He also appeared sad most of the time, according to the caregivers, and he also confirmed that he was indeed sad. He had low appetite, he was sleeping too much, he had no interest in any activity whatsoever at home, and this prompted his daughter to bring him to hospital because the family was worried that he may do something harmful to himself while in the house, because this was an unusual behavior to them. An assessment, however, he had no any suicidal thoughts or any attempts, no any homicidal. However, according to him, his main concern was progressive forgetfulness that had started about 3 years ago and had been progressive over time, or worsening over time. It started with forgetting mobile money and ATM PIN codes, and then progressed to forgetting conversations he had with people, recent conversations, and sometimes he started repeating himself multiple times in the same conversation. He also started misplacing items at home, and he could say that people in the house are hiding them from him or they've moved him. At work, he also started missing meetings because he would forget the dates of those meetings. This is work he has done for over 40 years. He would forget the important work material that he needs for these meetings and would frequently move out of the home just to go and pick, out of the meetings just to go and pick these materials, which became worrying. Over time, he started forgetting names of his own children. However, he could remember long-term events like where he went to school, the old-time friends he had made, his home village. He could remember things that happened with independence and politics. His long-term memory was intact. He was able to perform his basic activities of daily living, like feeding, bathing, dressing up. However, he had started having difficulty with instrumental activities of daily living, especially paying bills, managing his own money, withdrawing money either from the bank or from the phone, including transacting at work. And this made work really difficult and daily life hard for him. Over time, he started accusing workmates of evil intentions to get him out of the company that he had worked in for over 40 years. He also believed his phones were tapped. His workmates could listen to his private conversations. He stopped using his phone and then could continuously tell his family members to stop using their phones because he believed they were equally being tapped. He also believed that this symptom of forgetfulness, which is distressing him a lot, was because of evil eyes from the workmates. In this assessment, in summary, the following conditions were excluded. He did not have any signs significant for Parkinson's disease, no any chronic medical illness. He was not taking any medications, reported not taking any psychoactive substance. He had no history of head trauma. He had also not changed his environment, no home structure for a long time, which excluded out, most of these things excluded out other possible causes of similar symptoms. He, however, had a strong family history in the mother and the auntie, whom they reported that they had exactly similar symptoms. The forgetfulness was progressive in nature. The mother had passed on about 8 months to presentation of this gentleman, and by the time the mother passed on, she could not remember names of most of her own children and family members. Now, when we talk about Alzheimer's disease, we're just going to do really brief, but sometimes people confuse dementia with Alzheimer's disease. However, dementia is a general term. It's a very broad term that describes progressive decline of memory and other cognitive abilities that are severe enough to interfere with someone's ability to carry out daily activities independently. And that is not due to any underlying psychiatric condition or any other particular specific medical condition. Now, for you to diagnose Alzheimer's disease, it has to first meet the criteria for major neurocognitive disorder, which is dementia, the other term for major neurocognitive disorder. So this is the criteria specific to major neurocognitive disorder as per DSM. One, there has to be evidence of significant cognitive decline from previous level of performance in one or more cognitive domains. We are going to see a bit of detail about the cognitive domains. There are 6. Now, who determines this decline in cognitive function? It's either the individual themselves or a knowledgeable informant. For example, in this patient, we have the daughter who stays with him most of the time, or a clinician who has done an assessment. Should also be able to show substantive impairment in cognitive performance based on standardized neuropsychological testing that is usually done by professionals like psychiatrists or clinical psychologists. Then there has to be impairment in everyday activities. It could be just a minimum requiring just simple assistance with complex activities such as paying bills or driving, to actually significant impairment that could impair basic activities of daily living. It's important to note that the cognitive deficits do not occur exclusively in the context of delirium. So in other words, delirium has to be excluded. Criteria D of this is that these symptoms must not be explained by any other mental disorder, especially major depressive disorder and schizophrenia that could also present with forgetfulness, lack of concentration, sometimes lack of orientation, place and maybe person and maybe time as well, and also the lack of motivation. Now, once you've made that diagnosis of a major neurocognitive disorder, you have to specify what disorder it is. And in this case, we are picking out Alzheimer's. These are the other types of dementia on major neurocognitive disorder. This picture shows us the different someone saying there is echo.
Yeah, there is echo in the background. Maybe the other device could be muted, or the.
Let me try to do that. Is it better?
Yeah, I think that's
Okay.
good. And go ahead.
Okay. All right. So these are different cognitive domains, and we shall share these notes. Sorry, we shall share the slides for you to read a bit more. But for you to diagnose Alzheimer's disease, you should have impairment. You should have impairment in learning and memory as a key feature, and then in at least one other domain. That could be language, could be perceptual motor function, it could be executive function, social cognition, or complex attention. So it's a 2-step process. First, diagnose major neurocognitive disorder. Then 2, determining what disorder it is. And to determine that is 1, by picking out, excluding the other specifiers or the other types. And then also biomarkers. In Alzheimer's disease, it's significant, or the key thing there is that you have amyloid beta proteins, and then also the tau proteins that are really significant when you do the neuroimaging or even do the CSF analysis. So for Alzheimer's specific to DSM, I've already mentioned memory and learning, and then in one other cognitive domain. And then also there has to be impairment in functioning to a certain level, either with instrument activities or basic activities of daily living. There has to be a steady progress or steady decline, and it's gradual in nature. And then from there, you should have evidence of a genetic mutation, either from family history or genetic testing. So if there's a family member who has had a genetic mutation in any of the genes that are implicated, Alzheimer's, then you can confidently say this is what Alzheimer's disease. And then also there shouldn't be any evidence of mixed etiology, meaning other possible causes of the symptoms you're seeing. Since we are trying to get to the pharmacology, this is just a slide showing us areas that are mostly impaired: cognition, functional, and then there may be other neuropsychiatric symptoms, mood disturbances. For example, in our patient here, we see that had symptoms of depression, and also there are symptoms that suggest delusions, beliefs that workmates are against him. Tools can help to assess for different aspects. For example, the Alzheimer's disease cooperative study activities of daily living inventory can help with functional assessment. Mini mental state exam and MOCA can help with cognition. The neuropsychiatric inventory is specific to behavioral disturbances in a patient. This can be administered by clinicians to be able to fully assess your patient and support management. In the 2023 revised criteria for diagnosis of Alzheimer's disease, it has been noted that Alzheimer's disease is defined by its biology, okay? And therefore, biomarkers are very key in coming up to a diagnosis if you're able to do them, except that many of these, as we see, they are going to involve either biopsy or CSF analysis, and these are really invasive techniques. But now, how do we come to these biomarkers? We see that there are mutations in these different, the genes coding these different proteins. And because of those, for example, the amyloid precursor protein, because of the mutations, there's going to be alteration in the metabolism of these proteins or amyloid peptides. And as a result, they start to aggregate. When they aggregate, they start to form plaques that will later become toxic to the neuronal cells. And so they start to degenerate. That's what makes Alzheimer's disease a neurodegenerative condition. We also have the tau protein that could eventually start to be hyperphosphorylated. Tau helps with stabilizing the microtubules in our cells and the vesicles. So when it's hyperphosphorylated, it starts also to aggregate and starts to make microfilaments that now, I would say, bind together. And as a result, they make tangles that start to affect or become neurotoxic to the axons or axonal cells, and so impairing the synaptic connections in our brains, leading to the symptoms that we see. This is just a detailed description of the cascade of events that happens in the amyloid cascade. And this is for the tau. The slides will be shared since you provided your emails while registering for the session, so that you can have detailed understanding of the pathophysiology. So in the interest of time, I will move on to the actual treatment, specifically to the pharmacological treatment of Alzheimer's disease, which is the main discussion for today's session. So there are suggested approach. There are those that we are currently using, and there are those that we are not yet using. But in general, managing Alzheimer's disease is a combination of pharmacological and psychosocial interventions, and then also caregiving practices. So this particular session focuses on the pharmacological, and key things to note that it's very important to make the right diagnosis in these patients. The earlier, the better, because then you can try to modify the progression of the illness. It's also important that you know that this condition is progressive, and so you're going to constantly adapt the patient's management as per the stage they are in. And also, symptoms can differ from person to person. So the approach to one person may not be exactly the same for the other. So it's important to always assess. And new symptoms can always come up, including other medical conditions and psychiatric conditions that you have to treat alongside the treatment for specific to Alzheimer's disease. So currently, there are about 3 categories of the pharmacological approaches. However, we shall see that it's only one that is really actively in practice, and that is the symptomatic management. So with the symptomatic management, here we use pharmacological agents that are beneficial to improve the symptoms, especially the cognitive symptoms of the patient, and also improve their global functioning. And we shall be seeing these in details. Beyond those that are treating the Alzheimer's, we also have medications that now can alleviate other symptoms that may come in addition or as a result of the Alzheimer's disease. For example, psychiatric conditions like depression, sleep disturbances, agitation. Those are also medications that can help improve this patient's quality of life. The other category of the medications we have, or pharmacological agents we have, is the disease-modifying ones. So these ones are intended to delay the onset of the symptoms and also slow the progression of the cognitive and functional decline by trying to slow down the biological aspects ongoing, or the biochemistry that's happening in the brain, the neurobiology, especially with the amyloid proteins. Then also we have the regenerative treatments that are being suggested, though these are still in research. These ones are supposed to help with replacing the lost neuronal networks, though it's not yet very successful in reality, but it's also still under development. In the symptomatic management, your goal is to try as much as possible to delay progression of the symptoms, and these curves here are showing you the difference between a patient with untreated Alzheimer's disease and one who has had successful treatment. So the treatment is not going to cure the disease. However, it's going to delay the progression of these symptoms to really severe state. As you can see, the two curves, one up is untreated, and you see that the decline is quite steep and very fast. The one down, when treatment is initiated early in the mild stage, there's a bit of plateauing and slow progression to reach the severe state. When we talk about the symptomatic treatments, we have majorly in two categories. We have the acetylcholine inhibitors, acetylcholinesterase inhibitors, and then we have the NMDA receptor antagonists. So why acetylcholinesterase inhibitors? When the process or the neurodegeneration is happening in the brain, cholinergic systems or neurons are really affected greatly, especially in the areas where they are in high density. For example, the hippocampus, which is for memory and learning. And so that's why we see that there's a decline in acetylcholine, which is a major transmitter in the brain, and it's also very important in memory and also cognitive functioning of someone. Now, because there is impairment in the cholinergic system, there is a decline, or you're safe to say you can interpret as a decline in the amount or level of acetylcholine in our brain. We try to increase the amount of acetylcholine that is available for use in the brain in these patients. One way to do that is by blocking the enzyme, cholinesterase enzymes, that actually break down acetylcholine, so that we enhance the amounts in the synaptic cleft to be able to act on the postsynaptic receptors. And examples of the so far approved acetylcholinesterase inhibitor drugs are donepezil, we have seen this here, rivastigmine, and then galantamine. Those are the three approved ones. They are going to help alleviate the symptoms by trying to improve or normalize the amounts of acetylcholine in the brain. The other is the NMDA receptor antagonist. It's hypothesized that there is overstimulation of NMDA receptors by glutamate in neurodegenerative disorders, including Alzheimer's disease. And because increased glutamate causes excitotoxicity, we are going to have a lot of calcium being released. And as a result, we are going to have a lot of damage to the neurons, if I'm to say, and neuronal loss that could further aggregate the symptoms or aggravate the symptoms of the condition. So one way to try and manage the symptoms we are seeing and improve functionality is by trying to block or antagonize NMDA receptors so that we prevent the action of the excessive glutamate stimulation in the brain. And as a result, we improve the symptoms. The approved medication in this category is memantine, and it's usually given in moderate to severe conditions. So it's not usually the first line. Here is just a table showing us the different dosages of the medications and how to prescribe them. Key things to note when you're prescribing for these patients is that start treatment as early as possible whenever formal diagnosis is made. Treatment is more beneficial in mild to moderate cases, so the earlier the better. Also, treatment that the elevation of the symptoms and functioning is not long-term. It's not like for forever. It's just to slow down, but it doesn't stop the progression. However, for about 3 to 6 months, some reports have even said even a year or maximum 3 years, patients can have benefit from these treatments when initiated earlier than if started in late stages, because in late stages, you may not really get much benefit from them. Start with the acetylcholinesterase inhibitors, that is donepezil, rivastigmine, or galantamine. Always remember, start at a low dose. So as you can see, these doses are low. And then you taper them slowly over time. As you can see, you start to increase slowly. You start, let's say, for example, for the donepezil at 5 milligrams daily for about 4 to 6 weeks. Before then, you can think of increasing the dosages. Rivastigmine, we see that we increase every 2 weeks. Galantamine, we increase every 4 weeks. So you don't come and start at a high dose or start to increase very aggressively the dosages. It's also important that you establish routines, because I've already established that these people are having challenges with memory. So they are going to forget taking this medication. They may not be as effective as you expect, especially if there is poor adherence. So helping them or supporting them to be able to adhere to this medication is important. And then also doing regular follow-ups, at least every 3 to 6 months, to see that the medicine one is being effective and it's indeed helping by you doing the follow-up assessments, and also assessing for any side effects, and then weigh in if indeed the benefit outweighs the side effects of this medication. Otherwise, you won't be helping the patient if the side effects are more. Now we look at the other category, which is the disease-modifying treatments. These ones, they are supposed to halt or delay the deterioration of the patient's health by altering the amyloid degeneration and aggregation and degeneration of the neurons. However, still in research stages, but there are some examples so far that have been approved for use, although not yet showing so much benefit. For example, aducanumab and then lecanemab. They are so far the ones that have been approved. Prof will be telling us if people are using them on our current market or not. And they target different components of the disease. Again, like I mentioned, they are still under investigation, but this is exactly what is expected, that they'll be targeting the amyloid pathology. So if we have the amyloid plagues, let's assume now they give the anti-amyloid therapy. In this case, let's say aducanumab or lecanemab. Then it's expected to try and disintegrate these plagues so that we end up with, as you see, that expected therapeutic effect, a bit of lesser effect in the brain. And so with expectation that the symptoms will have improved as well, since they anticipate that these symptoms are more correlated with the amount of the plagues and also the degeneration that's happening in the brain. That is what I had briefly for you. And I'll hand over to the moderator to invite the content expert to give us a detailed account of this condition, especially in our setting. Thank you so much.
Thank you so much, Dr. Lillian, for those insightful, discussion in regards to diagnosis all the way to treatment of Alzheimer's disease. I will request still the participants to keep writing your questions and share them in the chat. We are going to discuss these questions in the next minute. So if you have a question, please bring it in the chat. So at this moment, I would like to invite our content expert, Professor Noeline Nakasujja, to give us a brief about herself, and then we go into the topic of today before we start the Q&A. Over to you, Professor. You're most welcome.
So, Mr. Moderator, thank you very much. Kindly give the brief about me. I'll go straight into the topic.
Okay, thank you so much, Prof. I take the honors. So Professor Noeline is a professor of psychiatry at Makerere University, and I may not list. It's a very big bio. I may not say everything, but with interests in geriatric psychiatry, and that's why we found it very important to have her insights into the topic of today. As I said, she's an associate professor of psychiatry at Makerere University, and as I said, still is specialized in geriatric psychiatry. So, Professor, if anything, I left out anything, I would, maybe you will mention it. Over to you.
Okay, thank you very much, Dr. Mwamzi, for the introduction, and all you're welcome that are online. Just let me know if you're able to see this slide I'm sharing. Are you able to see it?
Yes, Prof, we are able to see it. No, we are
Okay.
seeing the folder with the PowerPoints. I think the screen shared wasn't for the slide.
Okay. So as I pull it up, I just want to let the audience know that Alzheimer's disease is one of those conditions that are really increasing very much each day as people grow older, because old age is the biggest risk factor for developing dementia. Currently, there are an estimated 57 million people that have the condition. It would mean that we get about 10 million people acquiring dementia each year, translating to about one person developing dementia every 3 seconds. What that highlights is, how big this is a problem. The condition is mostly common after the age of 65. If people get it any earlier than that, then it's considered early onset dementia. And with each increase of every 5 years, the rate either triples or quadruples with increasing age. So over 65, we expect about 1 to 5% of individuals to have the condition. But by the time people are 80, sometimes you find that the prevalence may be about 40%. And as I've said earlier, the biggest risk factor is age. So I'm going to kind of group together my responses to the questions that were asked by the audience. But I also want to emphasize that the focus of this presentation today was more about drugs rather than anything else, because and the pharmacological management, because dementia management is very broad, as you saw in the slides that Dr. Lillian shared. There's the issue to deal with the psychosocial aspects of the individual, and then there's issues to deal with family who are very key players, family or, significant others who are primary caregivers for individuals that have dementia. So let me begin with, one of the questions that was raised was, how do we prevent dementia from happening in young people? That's what someone said, though I do get people who are in their old age also asking how to prevent dementia. And I'm flashing the slide that you're seeing. Please let me know you're seeing it.
Yes, Prof, we are seeing the slide of reduce your risk and
Exactly.
the different presentive. Yes.
Exactly. So that if anyone would like to prevent dementia, is a story that begins very early on in all aspects of our lives, from what it is that we eat, and we may not be able to go into the details of how each of these is done, but we have to eat healthy. The things that to avoid, fried foods all the time, non-balanced diets, excessive alcohol drinking, and abuse of, other substances. You have to be able to look after yourself in terms of management of things like hypertension or cardiac disease, because one of the other things that really causes damage to brain vasculature is hypertension, which would in the end result in damage to actual brain matter, and which can increase your risk for dementia. It is important for someone to stay connected. What does this mean? That you have social interactions, you do things that are pleasant things, maybe meet up with people for a cup of tea, play games with people, go to church, get involved in, activities around the places that you're staying, be part of clubs or groups, really keeping you socially interacted. And this can go on even into old age, so that people do not stay lonely, because loneliness also contributes to people developing dementia. You have to avoid head injuries if you can. If you're taking a boarder, make sure you wear a helmet. And also do not drink and drive, for example, because for sure you may end up with a head injury, and being very conscious of everyone who is around you and you avoiding harming other people in your way. Vision loss is another risk factor. So if at all you have impairments that have come as a result of age, that's the one thing that one can be able to ensure that it is corrected and managed appropriately. Hearing loss is another risk factor for dementia. So if at all there's challenges in this area, you then ensure that hearing aids are given, or any other kind of management that may be required to ensure that a person hears very well. We have to keep active, take walks. If you can run, take runs. If you can go to the gym and dance, go do that. But you have to keep active rather than staying in one place all the time. So, and these things you can do from an early age, so that you just age with it. It helps you reduce your risk for dementia. And have fun, play games with other people, do jigsaw puzzles to keep your brain active, and for fun, just to stimulate yourself. So I'll go on to, I'm going to stop screen share now and go on to the questions that people were asking. Just give me a minute.
Thank you so much, Prof. There's a question that was asked. I'm seeing there are quite many interesting questions coming through in the chat. There's a question that was asked by a participant as they were registering, that at what point should we start to think about medication in Alzheimer's disease?
So, Dr. Lilian, did tell you that the earlier you manage, the better it is for as regards prognosis for the individual. So the moment people start forgetting things and do not remember them later, because many people say, oh, I forget stuff, but oh, I eventually am able to find where it is that I had put the stuff. The moment you get to situations where you're forgetting and cannot remember, the case she presented at the beginning talked about this person who now eventually started accusing everyone within their space for having taken away their items or stolen their money, hidden their shoes, etc. It's time for you to worry that things are really are not okay, though that sounded rather very extreme. But if you're concerned for yourself that there's impairment that is impairing how you're able to function, it's time for you to come in for checkup. And when you come, the DSM criteria that she shared here is what we follow, that while you may be concerned, we also have to find evidence that indeed you have derangement in one or more cognitive domains that are now interfering with your functionality. That's when we make the diagnosis, and then that's when we start to treat. So
Thank you, Prof.
if we got a person coming in very late, they've been so demented, they are now even bed bound. It's really usually not very helpful for one to start medications at that point, because there's nothing you're going to be able to change if the person has already progressed and are very severely in severe stages of dementia. So Dr. Mwauzi, what I've done is that I saw some of these comments and I've kind of grouped them together in the interest of time. If you could allow me to talk about some of the things that I had seen.
Yeah. Thank you.
Is that okay with you?
Yes, it is. Thank you so much, Prof. You can
so there were a couple of questions on management. How do you manage dementia? What is the treatment protocol for the dementia? Which drugs do you get? And I think Dr. Nabwide did a good job in giving you the different classes of the medication, so I'm not going to repeat that. But what I want to point out is when it gets to treatment protocol, people love protocols, but for me, the basic protocol is take a history, do an exam, do the appropriate investigations depending on what the history is giving you, and then get a problem list of what that person might have. So people present so differently. You may get a person who is presenting with purely just cognitive impairments. You may get a person who is having cognitive impairments, but in addition, they also have maybe depression, or maybe they have a bit of anxiety, or maybe they are actually psychotic, as in they're having hallucinations and acting out on these hallucinations. So the management will then be as per the specific presentation of the individual. It is always very important to listen and listen to the patient for whatever it is that they're able to communicate with you, but also listening to the caregivers to understand where challenges may be in order for one to be able to treat this individual. It is not always that once someone has dementia, the only solution is with tablets or medication. A lot of it is to do with the caregiving and how to navigate the caregiving process. However, the talk this afternoon is not about that, because that's a whole big topic. We can always talk about it at another time, but just know that a lot of it has to go into appreciating things that need to be done for the patient. I will highlight some of them here, but we may not be able to exhaust all of them. So the other thing that people were asking about are what other medications. So what Dr. Nabwide did talk about were the drugs for the cognitive impairment or for the dementia, though in one of the slides she did also point out that sometimes you have to go by the symptoms that are being presented, and I've just mentioned that sometimes if someone has depression, you have to treat that depression. If they have psychosis, you have to treat the psychosis. If they have anxiety, you have to treat the anxiety. What one has to be careful about when it gets to older adults in prescribing is then you have to look at the side effect profile of the drugs that you're giving to these individuals. You have to be as safe as you possibly can for the drugs that you are giving. For example, if someone had depression and you wanted to say use amitriptyline, but yet they also have cardiac issues, that may not be the best drug for you to give. And you may want to look at other drugs, maybe an SSRI, like fluoxetine or duloxetine, or other medications that may not have severe side effects for the individual. If they are psychotic, for example, you may want to give chlorpromazine because that's what is easily available for you, but it may be inappropriate for an older adult because of the excessive sedation, and you want to avoid things like falls, because if they were to fall, they are also very susceptible to fractures. A younger person may fall and maybe not fracture themselves, but if an older person were to fall, it's very possible that they may fracture themselves. So you want to give maybe antipsychotics that are not very sedating. Now, as Dr. Lillian was presenting about the drugs that we have available for management of dementia, apart from Tacrin, the other drugs I'm aware that may be available. What becomes a limiting factor is the issue of cost. For example, between rivastigmine and donepezil, and they may not, some of them may not be as available. Sometimes some pharmacies stock them, like rivastigmine, and then other times they are out of stock. But for sure, things like memantine and donepezil are available for prescription. But as we've said, the prescription should be with a specialist with expertise in managing these individuals. They are not over-the-counter medication that you should just go and buy medication for yourself because you think, or someone who you think has challenges with memory. The newer drugs, the monoclonal antibodies like aducanumab may not be available, and it's still controversial about their usage. First of all, they are only been found to be maybe useful in early dementia, not moderate or late dementia, and yet most of our peoples here present quite late for treatment. There's also the controversy about the side effects that these drugs have, and I think Dr. Lillian highlighted it's still work in progress as far as their benefits and usefulness, even though they have been approved, at least in the USA. So I'll now move on to some of the common mistakes people make because I think something came up, what not to do, or when not, for example, when not to prescribe a medication, but it's going to be broader than just prescription. I have already highlighted that it's important to listen to the individual and take a good history to make sure that some of what you may be interpreting as difficult behavior for which you want to quickly sedate an individual may just need for you to change approach to this individual in how you manage them. So, for example, arguing with an individual who has dementia is really counterintuitive. There's really nowhere you're going to go by insisting to individuals, don't you remember this? Don't you remember me? Don't you remember we went here yesterday? How could you have forgotten? Those kind of things are really quite frustrating to the individual. And this needs to be a point, the caregiver needs, the caregiver here, I'm talking about the doctor, but as well as the caregiver in the home needs to be aware of these things. You have to speak slowly. Don't give too much information to the person because they may not be able to remember it anyway. But if you're relying on them recalling certain stuff, then, move slowly, take them at their pace. Do not ignore emotions. Do not ignore complaints. When patients say, oh, I have a headache, please look into it, because sometimes I get people say, oh, they say that all the time, but maybe there's nothing in there. It may be true that indeed that person may be having a pain somewhere, and you need to look into it and investigate it appropriately. Any change in behavior from what has been the usual for that individual is something to look into, to ensure that, to understand and therefore appropriately manage as to why there's this change and what are things I'm talking about. Maybe there's a change in their sleep pattern. It could be that they're in pain and something else has gone wrong within their body and you need to investigate. Maybe it's a change in appetite. What's going on? Or maybe it is a refusal to eat food. Maybe the caretaker or whoever is looking after this individual is pinching them and they are angry, but they can't express that for one to understand as to why this change has happened. So you really need to have a biopsychosocial investigation to appreciate why these people may be the way they are. Now, it is important for one to have a routine in managing these individuals. A routine for taking their medication, the specific times when they should be taking them. It is important that as you do your pharmacological treatment for this individual, that indeed they are in environments that are familiar with them, because that could also be the only problem, that if you change their environment, then they become a little more difficult for you to manage. And instead of you pumping them with more medications, that they are more irritable, I don't know what, I should give an antipsychotic. It may be just a need of appreciating that environment and ensuring that you manage these people in places that they are familiar with. There's a need for a lot of patience from the caregiver, and I'm talking about the doctor as well as the primary caregiver within the home, in appreciating how to deal with this individual. I'll pause for now, just in case there are other burning questions, Dr. Mwauzu, you may have seen, and you would like us to respond to, because we have 7 minutes to go.
Thank you so much, Prof. There are some questions that participants shared in regards to other alternatives that may be or that have been found to be effective rather than the treatments that Dr. Lillian shared. And one of them was asking, does dextromethorphan have any therapeutic effects in Alzheimer's disease? Another one was asking whether vitamin E. Yes.
Okay. I'm not about dextromethorphan for treating Alzheimer's, but there are other adjunctive therapies that are used, that have been tried. I think someone did ask about NeuroAid. What did they ask? Yeah, Neuromind and Neurotone, if at all really they do anything. We do not have evidence that those things are able to treat or reverse Alzheimer's, just like you saw in the pathophysiology, the emphasis that has been found is with the presence of tau and amyloid in the brain, which none of these drugs is able to. However, those drugs may activate the brain maybe in some ways. I have seen patients who say, you know what, oh, I was given Neuromind and I think I'm thinking a little clearer, but those are people who might have maybe MCI, which we call mild cognitive impairment, who haven't developed full-blown dementia, because for the dementia patients, no, it does not work. Drugs like ginsamine have been, historically found to be helpful with cognitive impairment. And I do use ginsamine. I do use things like vitamin E as adjunctive therapy. It may not work for everyone, but there is also need to exercise caution in their prescription because overdosages may be dangerous to individual. So whoever is prescribing also has to know the dosage and the limit within which to give. That said, I know that a lot of people have logged on for this call, even though they may not be psychiatrists. So I'm careful in giving out as much information just so people may not make mistakes, but also if at all you've diagnosed an individual and you feel you've reached the limits of what it is you can manage or help with this individual, as a clinician, you should know when to refer. Not too late though. Do not send to me patients who have severe dementia and you've been with them like for 4 years, and start and refer as appropriate. We'll always send back these individuals to you if they are within their their location is nearer you, for which you can be able to follow up with management for a time. And then if you feel like the course is not moving in the direction that would have wanted, you then ask them to come for another consult. All in all, I want to say something about prognosis before we close. If you start treatment early, patients are able to live for a little longer because they are able to slow the progress of deterioration, as Dr. Nabwide mentioned earlier. So if you want for a person to have a good prognosis, please start early with the management, and the management should be biopsychosocial. It is the biology of the medications that you're giving. It is the psychology of the individual in helping them appreciate their diagnosis if they still have some cognitive functioning to appreciate. And it is also for the caregivers that are looking after these individuals to see how best you can manage them. And it can be a beautiful story if all this is put in place, but it can also be very unkind if other things are also not catered for. This talk was not to talk about legal issues and wills and stuff like that, but all those other things also need to be looked into for the individual who is developed cognitive impairment and for which you're sure there's going to be deterioration for the benefit of not only the individual, but for the family as well. Thank you.
Thank you so much, Prof. There are 3 more other questions that burning questions in the chat. One of them was asking that what could be the best treatment option for a 75 years old who has failed on donepezil and galantamine, in brackets treatment-resistant Alzheimer's. The second one was one was asking to explain the dual mechanism of galantamine and why donepezil is preferred over galantamine in many settings, and if combination therapy is evidence-based, and he was asking whether there's a drug that can reverse Alzheimer's disease. Another one was asking at what point should palliative care set in such patients, and was appreciating for the session. And then another one was asking, do we start with cholinesterase inhibitors or NMD receptor inhibitors? Yeah, and whether we have memantine in Uganda. I think those would be the last questions.
Okay, so you said many things. I'll start with the last. We usually start with the anticholinesterase inhibitors before we go with NMDA, because as we said, donepezil usually may be a first line for stage 1 of dementia. But that said, it also depends on the clinician's assessment. There are times when I may combine the two because we want to minimize side effects profiles of each of these drugs when given to individuals, and sometimes combination may work, but it depends on the symptomatology presented and what it is that the clinician wants to target and clear first. Two, why donepezil versus galantamine? There's the issue of cost, there's the issue of side effect profile, and availability. And that's why we may do that in regards to prescription in Uganda. In other places, you may find that all they want to give is galantamine from the word go. So availability and cost sometimes dictate that. Dr. Mongs, what was the other thing?
Just about combining that. Is it evidence-based to combine the two?
Yes, because you see the evidence. For example, you may want someone to be alert during the day as they do their work, but at night if they're not sleeping very well, and then you know that maybe memantine might have a bit of sedation, could be very helpful in giving them, but it's not the norm. Please don't take it that it is the norm, but sometimes we do make a combination. Keeping in mind that you want to minimize side effects for the individual on the whole, and also keeping in mind that these individuals might also be on other medications. So you make a judgment depending on so many other things as to whether you can combine or not combine treatment.
Then if someone is failing to respond on donepezil or galantamine,
well, that may be right. So dementia is stage 1, 2, 3, or mild, moderate, severe. So as I said earlier, if it is a severe form of dementia, you may be wasting time. If you do an MRI and the brain is all gone, what are you doing? What benefit are you giving that individual by trying to put them on any medication? But as I also mentioned earlier, it is so important to take an appropriate history. What you may be interpreting as a dementia resistant, or treatment-resistant dementia, it may be because you fail to appreciate the social circumstances of this individual, and all you need to do is to listen a little more. So for me, I'll tell whoever asked that question, take a little more history. Take a little more history to appreciate what may be going on with the individual and get the appropriate management. And as I said, sometimes it's not the drug, it may be an issue of the psychosocial management of the individual, as well as advice that may be given to the caregiver on how best to approach care. Over.
Thank you so much, Professor. Thank you so much for your time. One was itching to know whether we have memantine in Uganda.
Yes, we do. It is available.
Okay. Thank you so much, Prof. And thank you so much, participants, for joining in for this session. We're already 4 minutes, extra minutes beyond 2. We're supposed to end at 2. And I would request all of us to turn on our camera for a photo quickly, and then we close the session. In the next 2-3 minutes, kindly turn on your cameras. Yes, I'll be taking the photo. And apologies for the extra minutes, but we thank you so much for your patience. Yes, I've taken the first one. Okay, the second one. And I hope everyone has seen the link in the chat for registering. Please do not lose the CPD points. And I think that's it. Otherwise, we welcome you to the next CME on the same day, Friday, at 1 in February. We shall be sharing the lookout for the flyer for the session. Every month we have these sessions starting at exactly 1 and ending at 2 p.m. Otherwise, I wish you a good afternoon. Thank you so much.